Welcome to the Simulation for Healthcare channel. I'm Jo, your host. I created these videos during the pandemic to provide a learning resource for my PGCert in simulation students. The positive feedback I received led me to believe that they may be of interest to a wider audience. This first video in the series is a fascinating chat with Tim Hodgetts from the military about how they use simulation to educate their soldiers how to react to major trauma in the field. If you have any questions or would like to suggest something you want to see in the future, leave a comment below. If you enjoyed watching, then please like, share and subscribe to my channel. Thank you.
My name is Jo Lawrence and I'm a senior lecturer at Brighton and Sussex Medical School, running a PGCert in simulation and with a particular interest in how we can use debriefing both in the clinical and the non-clinical setting. With me today to talk about his experience of simulation in the military is Brigadier Tim Hodgetts. Tim is head of the Army Medical Service and a professor of emergency medicine by background. Welcome, Tim, and thank you for joining me today.
Thank you. It's a pleasure to be here, Jo.
Tim, I wonder if you could start by telling us about your experience of teaching simulation in the military.
Yes, of course. And it's something I've been engaged in really since the late 1980s. I think just before we get onto that, it's worth just as understanding what the strategic rationale is, why we have simulation and why it's necessary to teach by simulation. And because particularly in our circumstance within the military, there are circumstances where it's just not feasible or acceptable to be gaining experience in a real life setting before you've actually deployed. And that might be because of infrequency of events. So blast and gunshot injury is actually very rare within the UK. So you can't get the experience unless you were to use simulation. Or, for example, when the real situation is unsafe or inappropriate for a training environment. So care under fire, tactical field care, these are not really environments to be training in. So you have to use the simulation setting to get people's confidence and competence before deploying them. I would also add, and this is a personal feeling, when I'm dealing with critically ill soldiers, that's not the time to be practicing either. You want to be giving your most senior clinician the opportunities to practice their art on the most critically ill. Again, make sure everybody's maximally trained through simulation. And then within the military, I think we have a hierarchy, which may not be seen as frequently across the whole of the civilian sector. And I'd say that we very much use micro simulation, meso simulation, and macro simulation. And if I can just explain what I mean by each of those terms. So micro simulation is about building your individual skill competence. So it could be relatively low tech, to do CPR, to do airway skills, to learn an IVI, to learn how to do intraosseous, or it could be requiring quite high fidelity simulation models, which could be synthetics or even a cadaver to learn, for example, surgical procedures. So that's the micro simulation, individual competencies. We've then got meso simulation, which is about building the team performance, whether that's the trauma team, the cardiac arrest team, the medical emergency response team on the back of a helicopter, our critical care air support team that flies in on a big aircraft and takes you from the ITU in the field hospital back to the intensive care in the home base. It could be the team within the blood bank to ensure that they're working in a cohesive way during a massive transfusion. Or it could be the hospital management cell to actually test them for managing a major incident. So we can look at specific teams within that meso simulation, and we can use again a range of fidelity. So we could have relatively low fidelity environments, simple mannequins, jointed or not, moving into the higher fidelity environment, which could include the mannequins that you can monitor, you can instrument, that may speak to you, that may wheeze, that may obstruct their airway, develop a tension pneumothorax, etc. So that there's the high fidelity end of that market too. Or indeed, we could use simulated live casualties, and it's something that we do use very frequently to test our small teams. So somebody from Amputees in Action or some other charitable company will come along and relive their experience of having one limb or both limbs lost in an explosion, while allowing those being tested to really feel the validity of that environment. Cadavers we do use on our surgical training course before we deploy people. That's called our military operational surgical training course, the MOST course. And live animals are an option. We do not use live animal training within the UK, but some of our allies do use live animals for surgical skills training. And then we've got macro simulation, and that's where you're really assessing the whole organisation's function. So you're assessing the whole field hospital. You're validating a field hospital or a primary care unit before it deploys, and you're looking end to end at the entire process, and you challenge it at pace over a number of days and see if they remember to get resupply, if they remember to empty their back door by calling in the evacuation assets, if they remember to get the resupply of blood as they start to use it. Because if you don't, you very quickly run into problems if you're not thinking of the whole rather than the individual teams within that whole. And of course, it allows us to test that timely decision making and understand if there's any risk being carried forward into the deployed setting, which we need to mitigate.
Mm. There's a real sense that the military totally embraces simulation, and it's in a very essential, from what you're saying, very essential element to their educational process. And what's really interesting is the amount of diversity in the way that you use that, which is actually really refreshing, because it sort of seems like there's no boundaries to that. So moving on from that, for us, we run sessions in a simulation suite with a high level of technology and maybe a technician to assist us. But for you, when you go out into the field, I guess that's somewhat different. Can you tell us a little bit about that?
Yeah, absolutely. And I think the key here is you've got to be inventive when you deploy, particularly if you're deploying on early entry operations, because invariably there's some downtime. And we want to be able to use that downtime to prepare the team for the for the next burst of casualties or for the next threat that we perceive. So we will be doing training when we deploy, but we might have to use relatively low tech or improvised alternatives. On a more established operation, particularly if we've got a large footprint of a hospital, we probably will have some training equipment brought out. So you may well start to find a mannequin or two being available for training. But let me give you some examples. So things that I've used in the field before, I have used a crunchy bar fresh out of the fridge to teach intraosseous. Now, actually, in a deployed setting where chocolates are rarity, it's could be regarded as a waste of a perfectly good chocolate bar, but you improvise where you have to. In terms of teaching a tourniquet, well, you can improvise a very low tech limb, so you can roll up 2 or 3 sturdy magazines and sellotape them to make your bone, wrap them up in a towel or two, and shove it down a trouser leg, and you've got something that is good enough for people to practice a tourniquet. And we do say don't practice tourniquets on each other, because tourniquets are only for life-threatening limb bleeding that can't be controlled by any other means. And if you train right, then you will practice right. So we've got to get the training right. And I have actually before set up an entire OSCE within the overflow ward of a tented field hospital in order to test a junior doctor who was due to go back to UK to take one of his membership exams. So when the needs must, then we will pull the stops out. But it's not all low tech. And one thing that worried me during the Iraq campaign, where we had introduced new bandages that were impregnated with topical hemostatics, that the soldiers who were going to use them had never before used them on a bleeding casualty, because you can't simulate within a plastic wound mold and a bit of water, even if it's red coloured water, it's not going to activate the dressings, because it actually needs platelets or red cells, depending on what the background ingredient is within the bandage. So what we did was that I went to the field kitchen and asked the rather bemused chef if we could have a piece of belly pork with the skin still on it, and then through the muscle, using a wire coat hanger that had been extended, push a Foley catheter through the muscle, and then clip it off at one end, and the other end a giving set connected to blood that had gone out of date, and it was otherwise going to be incinerated, and then cut down onto the catheter, make a nick in the catheter and put it under pressure. And all of a sudden, you've got a literally bleeding wound coming up through tissue. And if you warm the blood, it feels like warm, sticky blood, which the soldiers have never felt before. But they can then get their dressings out, push them into the wound, and because it's actual red cells, the bandage is activated and it adheres to the tissue. So they then go away feeling confident. I know how to deal with a genuinely bleeding wound.
I think what's so interesting about that is the amount of innovation and creativity and realism that you're trying to do whatever you can in a creative way to create that realism. And I think that's one of the messages we try and get through the course, is try and think creatively about how you can create a situation even if you don't have those high technology capability. And I think that's such a wonderful demonstration of how you can get that high realism with we probably wouldn't be allowed to do all of the things you did here, but you know, that's just perfect.
But absolutely, I mean, your boundary, your only boundary is your creativity.
Yeah, absolutely. Okay, so just let's move on a little bit from that, and I'd like to look at a little bit about the debriefing. In your debriefing, when you debrief in the field, how is that different to perhaps how you might debrief at home, and are there any particular tools or approaches that you might use?
Yeah, I mean, it's a big question, and perhaps if I sort of break it down into two parts. Firstly, just think about when I'm debriefing in the field, because there are three specific situations I would be thinking about, and then maybe some of the approaches that we might follow to that debriefing. So the three times that I would be looking at debriefing in the field. One is part of continuous clinical quality improvement. So it's to do with a clinical activity that's just happened, a resuscitation, for example, because you can't get better if you don't reflect and you don't actually analyse what's just happened, and then people agree what went well and what could have gone better. Therefore, we sort of reset for the next one. The next purpose, I would say, is around psychological well-being, whether it's of the individual in the team or the team itself. And there is very strong evidence in the literature, and some as recent as this year, when they've looked back on the evidence from Ebola and reflected it onto COVID, but where you can identify a psychologically savvy leader. These are the people that help their teams through the difficult circumstances and genuinely can demonstrate a lower prevalence of the common mental health disorders. So leadership is absolutely the golden thread to reducing the psychological impact of trauma. If I can just give you one example of sort of psychologically savvy leadership, is from when we were very busy in Afghanistan during the intense period in 2009. And really it's a conveyor belt of critically injured going on to one or two operating tables side by side simultaneously, survive, off to intensive care, die, to the mortuary. And it's so easy to sort of dehumanize that process, and it just becomes a conveyor belt. So if somebody died in the operating theatre, you have to remember that there was a real effort pre-hospital to get that critically injured to us, and then an extraordinary effort at the hospital. I mean, the whole hospital turned towards that individual, and you could easily have a team of 20, 25, 30 people working to try and save that individual. So just to say died, off to the mortuary, next one on the table, is just wrong. So I would call a pause, bring the padre into the operating theatre and say, everybody stop, whatever you're holding, put it down, listen and reflect, and just let the padre say a few words, so that everybody takes a moment to remember what's just happened. That, you know, we've all worked really hard, and unfortunately that individual has died. And okay, understand, we've got to move on, and let's now move on to the next patient. But people did appreciate that. One thing I did learn though is, don't put a tannoy message out for the padre to the operating theatre. I only did that once, because it went around the whole hospital and everybody then knows what's happening. We have to find another way of sensitively calling the individual. And then the third purpose, so alongside the continuous quality improvement and the psychological well-being, is sometimes you need it for discipline or behavioural change. It's only occasional, but it is sometimes necessary. And if I give you an example, I recall I was in the mortuary, just seeing someone who'd come in from pre-hospital who had died in an explosion, and was called, "Can I come quickly to the resus room? There's a casualty there," and the anaesthetist is sort of fighting over the patient. So I went into the resus room, and sure enough, two consultants fighting over the patient, and I just said, "Stop! What's the issue? Hear from you, hear from you. This is what we're going to do for this patient, and afterwards I will have a chat to each of you." And afterwards I would take them individually for a walk into the desert to understand why it is that they were squabbling over the patient, because that is not the time and place to be doing that, and just remind them that really appreciate what they're doing, but they're not indispensable. So you know, behave in a professional way at all times. So occasionally you do need that debriefing for the disciplinary purposes. Then if we get on to the approaches, there's a variety of approaches to debriefing. I think we've sort of covered when you'd have the simplest, which is after a resuscitation. We're all used to that. Difficult resuscitation, you've got to find time before the team bomb bursts away back to their departments. Just so everybody, just a couple of minutes, let's come together. What went well, and what could we do better next time? And something that I've really understood over the years is that people will perceive a good resuscitation because it was well led. It's not about the outcome. You can have a patient that survives, but the perception was it wasn't well led, and everyone thinks it was a terrible resus. Yeah. But the patient can die, but because the resus was well led, it felt calm, it felt logical, people felt everything was done that could have been done, then people walk away from it thinking, well, you know, we did our very best. It was good in the sense of a well-led resuscitation. So again, back to leadership, but in an austere environment, you can't also get away from the resource element, because you are working with finite resources, whether it's the people that you've got, the equipment that you've got, the blood supply that you've got. There is inevitably some feedback around resources when things haven't gone as well as you would have liked them to. So that's the simplest. And then moving on in terms of complexity, I'd say that After a significant event, or perhaps after a major incident, there'd be a more formal debrief, pull people together. I mean, yes, there's the immediately after, before people disperse, getting a very quick feedback, but then a number of days later, a more formal process. And certainly within the military, we have learning accounts, we have after action reviews. It is very formalized. We have processes for organizational learning, which we absolutely stick to. Those debriefs can include a written element as well as just verbal. So we absolutely do capture the lessons. Then at its most complex, I would draw attention to something that we have done aggressively since 2004, which is our, when we have a unit deployed, is our weekly audit and case review of all the cases that have gone through that particular unit, particularly anything that classifies as major trauma, so something that is somebody who's seriously injured, or if there's been any deaths, whether those deaths were pre-hospital or deaths were at the hospital. So it's highly structured, it's very consistent. All of the stakeholders from pre-hospital, in the deployed setting, and then back in the UK who are receiving patients, they're all involved all the way through to the rehabilitation centre. So you've got pre-hospital people and rehabilitation people on the same all-informed net on a weekly basis, so that people who are further downstream can say, well, actually, if you'd done it this way, we might have had a different outcome. And because they're learning about it while they are still deployed, they will change their behaviours. There's no point just doing that 6 months or a year down the line in a written report, because you missed the chance of actually changing anything. The person isn't there anymore. So it's a very, very powerful way of continuous quality improvement on a week-by-week basis, and it's why we demonstrated extraordinary outcomes because of that aggressive governance.
Very action-led, isn't it? It's a sort of, the response is, it's just the kind of things that I think we're missing within the health services. We don't do enough of that repetition of follow through, and that's a great example of how we could make a difference. You touched on there, Tim, in that conversation about psychological safety. How difficult in debriefing is it to provide some level of psychological safety when you're working in that very challenging environment?
Well, it can be very difficult, and I think I'd say that you can't have full psychological safety when you don't have physical safety. So when you're being mortared regularly, and you can hear the explosions and the mortar alarms going, and you're lying face down on the floor, then you're right at the bottom of Maslow's hierarchy of needs, thinking about your own safety, thinking about perhaps when your next meal is going to come from, or your next phone call home. And it is difficult then to be fully psychologically safe. Having said that, psychological safety will come from the leadership style. So if people feel that you are approachable, that you're acceptable, that you're open to or acceptable of constructive challenge, that you're willing to listen, that you're humble through that, then they will come to you. And they'll also come to you if they know that you're going to do something about it. So if through your actions you have shown that you are decisive and you will put things right if people give you a problem, and you'll do it promptly, then they will absolutely give you their issues. Now, there are some times as well, I think as a clinical leader, when you've got to know that there's nothing for your juniors to learn. So, for example, in the mortuary in Afghanistan, I banned the junior doctors. There was no need for them to see an individual soldier in 11 body bags. What is there to learn from that? Absolutely nothing. So you protect their psychological safety by not exposing them to things that they really don't need to see and have nothing to learn from. And I think despite an unsafe environment that we've talked about, that the strength of the team absolutely comes from some of those shared circumstances, the mutual support that you build in those shared circumstances. And I'd say that emotional intelligence runs pretty high in a deployed team. People are looking out for each other. They are looking to spot if someone's not behaving to their norm, and therefore be prepared to challenge. What's up, mate? What you don't seem your normal perky self, or indeed don't seem your normal grumbling self. When soldiers stop grumbling, then there's something wrong. When they stop grumbling about the food and that the boots don't fit, then you really do know there's something wrong. And I'd also say that in the deployed setting that you do develop some coping mechanisms. Now, of course, you've got your professionalism, you've got your training, you've got all that simulation that you've done before you're deployed that gives you a degree of resilience to the circumstances. You've also got dark humour, which is quite prevalent in the military setting. But to a degree, you've also got some fatalism. That if you are accepting of the circumstances that you are in, then you can cope more. And certainly when I did the flying on the helicopter forward to the point of wounding, where you could literally be flying into a firefight, well, you go in the mess tent at lunchtime and it's chips, and you go in the evening and it's chips again, because you're not thinking about the following day. You're just thinking, well, that satisfies me now. It's good for the soul. May not be good for the waistline, but it's certainly good for your mental resilience.
And I guess that you touched on the resilience side of things, but from your point of view, how much do you think doing sort of rehearsals through simulation helps provide the soldiers with resilience to what they might encounter? Do you think it plays an important part?
It's absolutely critical. It's right at the centre of it. And if we go back to Gary Player, the golfer, that the more I practice, the luckier I get. I mean, of course, it's nothing to do with luck. It's everything to do with practice. And it's getting things into your muscle memory. It's why soldiers do drill. We drill soldiers because we don't want them to think in a crisis. We actually want them to react, that they've been trained, weapon firing, weapon stops. Then they go through a series of muscle memory drills and their weapon starts firing again. Similarly with first aid, we teach them battlefield casualty drills, BCD, so that they learn what to do when somebody has catastrophic hemorrhage from a limb, and they learn what order to do the life-saving skills, because by turning them into drills means that when under pressure, then it is automatic. You're at sort of brainstem level rather than having to do deliberate thought. And remember the 6 P's in the military, that prior planning and preparation prevents poor performance. And I'd also say that that's no more important than for ethical considerations. Where I've found real difficulties on tour is where time hasn't been taken in advance in the training setting over the simulated casualty to discuss the ethical issues, because the time to have that ethical discussion is in the simulated setting, not over the patient in crisis when you've got a major incident running, and you actually need to have that sort of agreed pathway forward, because there will be ethical challenges in a deployed setting. Now, previously I'd have said those ethical challenges are never seen in the NHS, but they have been in COVID, because literally intensive care units have been overwhelmed, and you therefore have to make a decision. Well, who am I going to ventilate? How long am I going to ventilate that individual for? What additional treatments am I going to give? If I've only got a finite amount of treatment resource, be that a novel drug for COVID, or be it a blood and plasma resource for the trauma injured, how much? What's the ceiling for an individual patient? And these are really difficult decisions, and you need to make them up front so that everybody's then consistent and comfortable when it gets into the deployed setting. And if I give you just an example, perhaps to finish off with, I recall a young Afghan girl who'd suffered a serious leg injury from an explosive device, and she was brought in on the helicopter with her mother. And her mother said, through the interpreter, she is not to have her leg amputated, because if she has her leg amputated, she will never marry, and we don't want her in the village. So the surgeons thought that an amputation would have been appropriate, but they attempted to salvage the limb. And a number of days down the line, the limb became gangrenous, which was really what you probably would have expected from the outset. And then the decision was, well, we have to take the leg off now, otherwise the child would die. And the mother said, through the interpreter, I would prefer her to die than to come back to the village without a leg. Well, whose ethics do you then follow? Do you follow the framework of ethics that we've been brought up in the UK, whereby, of course, we're going to ignore what the parents say and do the best for the child, because you've got a duty to look after that child? Or do you follow the sort of the local ethics, where if you do take the leg off and send that child back to the village, she's just going to be left in the corner and not fed and ultimately die? So very, very difficult. In the end, and we had to make this decision quite quickly, but it was quite a heated ethical debate. We said we're going to take the leg off. But fortunately, in the intervening period, the nurse had convinced the mother that taking the leg off was the right thing, and the mother had accepted it. So we ended up doing the right clinical thing and getting acceptance from the parent as well. But it's that kind of ethical challenge which you really do need to simulate. And although it's not involving technical skills, often it's the decision making, not the technical skill per se, that is going to be the most difficult part of your resuscitation.
Gosh, thank you. Well, quite clearly huge challenges, and ones that we have seen a little bit in COVID, but have not really had the experience of like the military have. But I think what it does say to me is what a refreshing thought to have that commitment to the simulation and the role that the military see it playing, and the benefits that it has, and also towards that creativity in thinking out of the box to find ways to create that simulation if you haven't got all the tools that you need. So Tim, thank you so much for giving up your Sunday to join me today, and for providing us with such rich insights to the world of simulation in the military. Many thanks.
Thank you very much.
Thank you.